First thing that you should explain to the professor is what is the organ that you are observing. So what is this organ here that you're observing and how did you recognize it? How did you recognize that this is a lung? I know that the question seems stupid to you, but you should be able to answer these questions. Yes. Okay, I'm going to put a specific place of it on the screen, and you, one of you at least, is going to give me a description of what you're able to be seeing so that we will check up for mistakes of understanding. What do you see here? Okay. Specifically here, I don't see a bronchial epithelium, so that I would call this region filled with bronchi. I would majorly describe this field as alveolar spaces and alveolar septi, which are filled with fluid and inflammatory cells, and there is severe hyperemia in the septi with dilated vessels filled with erythrocytes. With bronchus, not exactly here. I'm going to show you now a bronchus. This is something that I don't discuss to be a bronchus actually. This is a vessel, this is a vessel. Bronchus. Yeah. There it is, a bronchus covered by respiratory epithelium. It's a little bit smashed and desquamated, and inside it's filled with inflammatory cells, but the respiratory epithelium is well recognizable. Here, what I see are lots of dilated vessels, filled with erythrocytes. There is fluid inside in the alveoli. And inside in the bronchi, I see inflammatory cells as a mixture. Or take a look at the desquamated cells inside in the bronchi. Lots of respiratory epithelium also inside. Do you see it? Ciliated, mixed with each other. This is respiratory epithelium, which is desquamated by the wall of the bronchus. Lots of erythrocytes mixed with inflammatory cells. And there is even some pigment here. What is this pigment? Let's see your answers. Anthrax. No. It's completely not anthrax. And it's when you see anthracotic pigment, I believe you wanted to answer this. Anthrax is infectious disease which is having three forms and it's having nothing to do with anthracotic pigment, which is carbon particles, yes, from the air. But this one is not. Anthracotic pigment should be, yes, hemosiderin, exactly. Anthracotic pigment should be situated either in the septi of the alveoli or around the wall of the bronchi. And here, it's inside in fluid. I'm going to show you exactly a field with anthracotic pigment. It's appearing blackish. Do you see it now? Well, yeah, that is here exactly anthracotic pigment. Yes, I know what you meant. You understand each other. Okay, so what is important for this slide? When you describe that it's a lung, that it's suffering severe hyperemia, pulmonary edema, all of the alveoli are filled with inflammatory fluid, which is majorly made of erythrocytes. And take a look at these cells. I'm going to ask you, what are these? Let's just find a larger field with inflammatory cells. Well, this is exactly actually the field that I'm going to ask you about, but let's check out what are these cells. What are these inflammatory cells here? With segmented nuclei, couple of these are suffering lysis and are releasing sort of enzymes inside in this fluid. These are neutrophil. Great. So, great. So, these are neutrophils. Take a look at this formation here in the lung, which is actually sort of rounded, well circumscribed. There is complete lysis of parenchyma on the inside. Grossly, it might be a field filled with pus. And next to it, we have sort of a not well observed demarcation by hyperemia vessels, which might be well recognizable. So, what is this cavity here which is formed? Great. This is an abscess cavity filled with pus or neutrophils. How many types of abscesses you know from general pathology? What type of inflammation is the abscess? Is it acute or chronic? You don't see the pus yellow at the microscopic slide. You will see it grossly yellowish. Histologically, it appears bluish because there are lots of neutrophils on the inside. But grossly, yes, it appears yellowish due to pus. That is acute inflammation. Great. So how many types of abscesses now you know? Well, yes, one is well capsulated and the other one is not well capsulated, but how do we mark them? How do we call them clinically? It's acute abscess and chronic abscess, not depending on the idea that both of these go at the form of acute inflammation. So it's acute abscess and chronic abscess. Does the acute have a good demarcation? No, it's not having a good capsule, but can't remember which is which. Yeah, no, capsule is actually the acute one. It's having a small demarcation of inflammatory cells. The chronic one is having well seen demarcation at the form of a pyogenic membrane. It's something that you should remember from general pathology. And if you don't remember it, read it again. I'm going to make the hints on what the professor is going to ask about the slides. Now, next. How many types of pneumonia you may know? Acute, chronic, visceral, viral, bacterial, Krupus, or eventually local and focal pneumonia where you don't have diffuse engagement of the lungs, and abscedating, which is actually an abscess shown here at the field of pneumonia, is complication of pneumonia. It's actually when the pneumonia change is not treated. Sometimes they form abscess cavities, and those abscess cavities might be either well demarcated by pyogenic membrane or not well demarcated. That is connected with the time for which we find actually the abscess. Since this is a huge amount of pulmonary tissue, I suggest it was taken from a dead patient with pneumonia, which was absceding. Is this one clear? Do you have any questions on any field of this slide?